That's exactly like it's
Oh, we do?
but we'll see what happens. I think we do years watching me up there being a big dog. I can remember when sitting in morning report, writing the residents. Now she's up here writing the entire.
Hey, red dinner.
Thank you.
I'm getting red.
Thank you very much.
I'm the. Oh, great. I can grab a coffee.
Oh, it is nice. Okay,
Love it.
wonderful. Okay. Well, I planned on my talk running longer, so I figured you would want to give me a head start. So I was just trying to, plan ahead. But no, these are good talks. I'm excited to hear them. Right. Thanks for the chance. What were you doing? So I used to play, I recognize I'm short. But I played super competitive volleyball until I went to medical school, really. We went all over the nation, California, and played. My daughter finally wanted to start playing again. So I was coaching her. And then she was like, Dad, why don't you start playing like you used to play? I was like, I'm a little older. I don't plan to do that. And then I was like, why not? Like, why not start playing competitive again? So I started training for it, running, jumping. I had I used to have like a 36, 30 in the vertical. And still at almost 50, I can still stand and jump the box that's 32 inches. I can still stand and jump on top of the box with straight legs. And still can jump. Yeah. So the first tournament that I decided to play competitively, really it wasn't really a tournament, it was just kind of a practice, just kind of a warm up for the real tournament. We were playing, not only was going to play for an hour or two, but I felt good and everyone wanted to keep playing, so I played for 3.5 hours. And about the 3.5 hour mark, my body said, "We're done. We're done." And that's a great injury, though. And honestly, January 15th. Walked to a lot round, I would never guess that you were injured that way. I don't like it. Yeah. And they couldn't operate on it, like buckle belly. There's like 3 zones of the Achilles, or like zone 1, which is like right after calcaneus, which is actually the best one to have, because they can either screw it back in and suture back to the calcaneus, but pretty much the entire Achilles inserted. And then a low zone 2 would be next best one, still still there to put back together. But a high zone 2 and a zone 3, zone 3 is from the muscle belly. Exactly right. And then it's already splayed out, so there's nothing worth anything. So they non-opted. So I was in a cast for 6 weeks, they put you in a cast with your foot down, the Achilles doesn't stretch, it needs to be short, otherwise it'll feel long, and you will never have any power. Yeah. Sort of counterintuitive just on the surface, right? You think like if you feel it short, it's going to be contracted, it's going to be hard to stretch. Well, they can stretch it back out. Yeah, but if you heal it with not long and too long, you'll never have any strength. Interesting. That makes sense. So they put me in a cast, my foot down at like 33 degrees, which you never had it. It's really hard to explain that high heels. No, because at least with high heels, they give you a heel so you can stand on it. But they don't want you standing on it, so they just put your foot like this. You can't walk. You can't mean like if you go to walk, your knee will automatically tighten because they cast it all the way out to the toe. Yeah. There's nothing to actually do your monopare, literally. And then they put you in a boot with the heel raised. It's very painful. I still have a big bruise on my heel that hurts. And then finally, I let you get to a shoe with the heel raised, and now I'm out of the heel.
I think so. The moderator maybe sit there.
It takes. I'm sorry I didn't go through that. I'm playing pickleball, and
I need to bring up another chair and scooch closer.
A little bit about pre-operative prehabilitation. I don't have any financial disclosures and I don't feel very qualified to be giving this. And I'll kind of quantify that as I go through this just a little bit. So I want to have a talk that is evidence-based, but I think what you're going to see is there's not a lot of evidence on this topic. There's a lot of anecdotes. There's a lot of this is how I do it. But when you really critically review the literature, there's just not a lot of evidence on does prehabilitation work. So as I started studying this topic, I started trying to take a little mental shift around some concepts that I had. So if you go to the American College of Surgeons website, this is the definition of prehabilitation taken straight from there. It's defined as a process of improving the functional capability of a patient prior to a surgical procedure, so the patient can withstand any postoperative inactivity and associated decline. In other words, you get to a better place physically before an operation. That's how I typically have thought about prehabilitation, getting people as strong as they can before surgery. So what are the components of prehabilitation? You know, obviously optimizing exercise physical, but I'm going to contend there are some other components that wrap around prehabilitation. Maximizing pulmonary function, optimizing nutrition status, improving exercise. What kind of medications do we do in a prehabilitation? And I'm going to cite one paper in the bariatric literature that looks at preoperative prehabilitation and medical management. We would also like to think of our enhanced recovery programs as a little bit of prehabilitation and really anything else that may improve postoperative outcomes. And we're going to see as we go through this. So when you look at what happens after surgery, so we look at a lot of, we have studied very in depth when we injure someone by operating on them. They have all kinds of different hormonal changes, cytokines, glycolysis, proteolysis, lipolysis, hyperglycemia. We all know about that. We really know what happens after we cut on someone. What we don't really know is what do we need to do to optimize that patient. So this was a great diagram that helped me put this together. So prehabilitation looks at how do we optimize the stress response that comes along with surgery? What are the things we can do to optimize the stress response of our patients? We're pretty good at enhanced recovery now, and we're pretty good at stratifying how that improves hospitalization. It decreases length of stay, decreases complications. But what can we do leading up to that point where we start to put enhanced recovery? And what does the data say about it? This is something from the gyn-onc literature that really, when I saw this, I was like, I got to think of this as something other than my patients exercise a little bit before surgery and just get strong. When you look at this, they define prehabilitation as medical optimization, physical intervention, nutritional intervention, and psychologic intervention. So when you think about really a comprehensive multidisciplinary approach to prehabilitation, it's not just having people exercise more before surgery or making sure that their pulmonary status is where it should be. It really is a comprehensive look at all the different things that we can do prior to surgery to help optimize outcome. Well, what does the data say? So what does the data say about prehabilitation? So really, when you look at this, there's not a lot of data. I wish I could tell you there's robust data. Really, where a lot of work is being now is in rectal cancer patients in prehabilitation. There's a lot of work in that little zone of that little subset of general surgery. But when you look at this multimodal prehabilitation in patients with low functional capacity at baseline, only 72% of patients experienced an improvement. And really what a lot of the studies do is they look at the studies have not shown there's a good increase in outcomes, but they'll look at where's the patient in 4 weeks? What are they able to do in 6 weeks? What's their quality of life? That's really the data that they're looking at, not does it decrease hospitalization, because the data just hasn't supported that. When you look at this, prehabilitation, this is a very recent paper. A lot of the study, just like enhanced recovery, is done by our anesthesia colleagues. We're not doing a lot of this study as in the general surgery group, but here you go. Prehabilitation is a high priority intervention. In this umbrella review of 55 reviews, there is evidence that prehabilitation may improve rates of complication and non-home discharge. However, the certainty of this findings was low. So the things that we think are going to work, it's just not panning out in the literature. What about in older and frail individuals? Those are the people that we would intuitively say, you have someone who just looks sick coming in the door. If I can make them a little bit healthier, what's the outcomes? And again, it's showing the potential to diminish postoperative outcomes, but the data just isn't there. What about preoperative assessment and prehabilitation patients with obesity? We all operate on obese patients. That's around the United States, all of us have that, regardless if you're a bariatric surgeon or not. But we can see here that the only thing that they found was making sure that their sleep apnea was treated. And that's borne out in our literature over and over again. What about thinking of it prehabilitation in different rooms other than just improving functional status? What if we could optimize exercise, optimize nutrition? What about pharmacotherapy? What about the GLP-1 antagonists? What about that? What if we can optimize people in a prehabilitation? What do the outcomes lead to? And the fourth is psychological support. And most of my practice is bariatric surgery, and I didn't really think that we are already prehabilitating our patients before we operate on them. But I wasn't thinking about the psychologic, really the nutritional optimization that we try to do. But we are doing it, but not by the definition. When you look at the definition, it was preoperative physiologic status. Really, we are because it's a multidisciplinary approach. So as you can see here, what are the advantages from exercise? You see aerobic training, nutritional interventions. What if we give them a GLP-1 agonist? What if we treat their diabetes with a GLP-1? We're finding that preoperative diabetic control will improve their postoperative glycemic control, postoperative complications. So again, prehabilitation can be something more than just having our patients exercise more. Well, Cochrane did a very large review of this. Does it work? Does it not work? And this is what they found. So the conclusions: postoperatively, prehabilitation may improve functional capacity. Prehabilitation may also result in fewer complications. Prehabilitation may also result in higher readmission rates. The certainty of the evidence was low. So you can see here, there's a lot of discrepancy about what is the role and does it work. And it's quite interesting because if you read this paper, they actually go into more depth about the author's conclusion, and they basically said, we have no answers. The American College of Surgeons has provided us something, but I would contend that this is something my interns learn in their first or second month. They can go through this checklist, which is, do they have stable cardiac disease? If no, they see the cardiologist. Do they have stable pulmonary function? If no, they see the pulmonologist. So when I see this patient come to my office, do you think they need to have prehabilitation? I think everybody would agree this is a patient that would need some prehabilitation. But if you think of it in terms of psychologic screening, diabetic screening, making sure their sleep apnea is taken care of. But what about this? What about this kid? What about the 22-year-old who has rectal cancer? Do they need prehabilitation? I would contend there's a psychologic component. There can be a physiologic component. They can probably benefit from it as well. Or what about this? What about the young lady with breast cancer? If you think about prehabilitation from a different realm and look at it, what's the psychologic impact? What can I do to optimize their psychologic state before they have surgery? Can really help them attack these really aggressive diseases at a young age in a much different realm. So really what I want to do is just plant the seed in everyone that when we think of prehabilitation, we typically think of it as making sure that they can withstand the surgery from a physiologic standpoint. But there really needs to be a comprehensive approach to prehabilitation that includes psychology, nutrition, really all components that I think can really do that. And the second thing is we need to study it. because it just has been ill-defined and ill-studied.
All right, we invite questions. Great talk, thank you. I mean, there's so much push for this, right? In recent, like a month ago, I got a call from our IBD center. We want to come and train you. We're doing the pre-op program for our IBD patients. Why do you think with lack of any robust data that this thing has been propelled forward so much?
I asked myself that question a lot in preparing for this. I think it makes sense. I think anecdotally, we see that patients do better. It just to power a study of that size is just astronomical, the number of patients that you need. There is an ongoing trial in Europe right now that is a randomized trial, and they're looking at, I think they're going to look at 50,000 patients. But it'll take probably 10 years to get the results of that. A few of the papers describe the trial, but it's been in the last year, like, we're going to do this study. But I think you're seeing the push because it's like enhanced recovery early on. People said, let's do it. And then they did it and studied it. And it turned out that it was that's what it is. I think you're going to see that in this as well. The push is do it, and then we'll study it. And I think we all know there will be some improved outcomes. Yes.
So what do you think are the biggest barriers in implementation of these rehabilitation pathways? Is it patients related, system related? And the second question is there any role for rehabilitation in trauma patients, or like, what are your thoughts on this? Thank you.
What was the second question? I didn't quite catch it.
Is there any role? Now it's
Yeah.
working. Yeah. Is there any role for rehabilitation in trauma patients, or like, if any, what's your thoughts on this? Thank you.
Sure. So the first question is, what are the barriers? I think there are multi-barriers. One, I think it's a system issue because we just don't have robust rehabilitation programs developed. The second layer of that is going to be a payer issue. Who's going to pay for a program like that? Most payers are going to be reticent to pay for something that hasn't shown in the literature. And when they go to the literature, they're not going to find a whole lot. So I think those are the two big barriers. I think if we can build the systems and show it, then I think the payers will eventually get on board. And then I think your question was, what about it in a trauma patient? Boy, I tell you, it's really hard. That one would be a little bit more challenging. I think you can start the prehabilitation after the trauma, but to prehab someone before a trauma, it would be a huge challenge.
Bridget Fate from New Mexico. Thanks a lot. This is something we talk about and think about a lot in our group because I feel like we always think our patients are the sickest, but I think there's the group out at Anderson who's done a lot of work. I'm a surgical oncologist. This really has to be portable. This has to be sort of app-based. This has to be able to be provided in the elective set for the elective patients, not the trauma folks. Thank God I don't have to take care of them anymore. But, where it can be happening in their home, because you can't be having patients try and drive an hour and a half to go see a physical therapist locally. I'm wondering if in your review, who's got the fix for that of bringing the prehab to the patient?
Yeah, this is still such a budding area that there was really no good fixes to some of that. Most of the studies are done at very large institutions where distance isn't as big of a deal, but I think your point is very, very valid about bringing it to the patient.
Hey there, great talk. Very interesting. Thanks for giving. I'm Terrence from UNMC. So my thought, when you hear medical optimization, nutritional optimization, cardiopulmonary, it all sounds very intuitive that they would have better outcomes. But we also have our systems kind of aim towards PCPs, family medicine to have taken the role of that previously. So in your research, did you come across, instead of building new systems to kind of tackle this problem of having prolonged prehab in place, any systems that were using systems that were already in place, partnering with PCPs and family medicine? And do you think that's perhaps a better approach?
Yeah, I think the figure that I showed you from the GYN-onc literature, that was them describing how they did it. And that paper was only from maybe 2 years ago. So again, this is still, the systems just haven't been in place. That was probably the most robust paper that I saw about the multidisciplinary approach. to that. It's the literature is just still so new that it's more, this is how we did it, not really how do you port it and who's the best players on the team.
Thank you.
Perfect. Thank you. All right, next talk titled Inguinal Hernia to Repair or Not. Dr. Alexander Rains is the Assistant Professor, Director of Robotic Surgery, Residency Program Site Director at the University of Oklahoma. Thank you.
Good morning, everybody. Appreciate the chance to be here. A little intimidating. Is that better? Good morning. A little intimidating to stand in front of a bunch of surgeons who have fixed a lot more inguinal hernias than I have, but very thankful that in my young career, I've had a robust practice and fixed a lot of these. And so hopefully I can teach you something today. The underlying theme of this is, do we fix them or not? Patient comes to your clinic with an inguinal hernia. Do you just inherently fix it, or do we have a decision plan with that? In terms of disclosures, I do have a disclosure. I have a relationship with Intuitive Surgical, so I do a lot of robotic surgery. I made a point to not include any robotics data in this talk. Of note, I still don't accept any professional fees from Intuitive, and my financial advisor says I'm stupid, but do it because I believe in it. For objectives, we're going to talk about just current data and trends. Where are we at with inguinal hernias? What are considerations when and how to repair these, and some general special considerations in inguinal hernia. So what we know, inguinal hernias are common. 20 million repaired across the globe every year, 700,000 of those in the US. The best data I found on emergent repairs was that 9% of all inguinal hernia repairs are done emergently, which is too high in my opinion. I also think that's a high number based on anecdotal numbers, but that's the best data I could find. We also know that inguinal hernias are more common in men. Throughout this talk, I'm going to argue that we need to pay more attention to inguinal hernias in women as well. We know that indirect defects are the most common across both genders, and we know that femoral hernias are at least historically reported as more common in women. I'm also going to argue that we need to be looking for femoral hernias in men as well. We go through these treatment algorithms. I think those have been underreported largely because of under dissection. We'll talk about that. So you have a patient that comes into your clinic. They have a hernia. They noticed a bulge in the shower, or their pants aren't fitting like they normally used to. Do we need to fix them? And the very first question is, are they symptomatic? Are they asymptomatic or minimally symptomatic? There have been randomized trials that talked about watchful waiting versus surgery. And we know that acute complications in asymptomatic hernias are very uncommon. We know that pain scores over the first 2 years of a known hernia are similar whether you fix them or not in the asymptomatic patient. We also know that over time, most patients do develop symptoms over time. And at 7 to 10 years, 70% of patients have symptoms that end up having surgery. Common question that patients offer us or ask us is, well, I have a hernia, it doesn't hurt me. Do I need to change my life? And we also have data that shows that there's no evidence that physical activity increases the risk of hernia incarceration in asymptomatic hernias. This led to statements and recommendations, international group called Hernia Surge. Some of the data that I'm presenting is from them. Basic recommendations from them. First off, there's low risk of complication not operating on someone who does not have symptoms. So just by virtue of having a hernia with no symptoms, you do not need to operate on that. With that said, we know morbidity and mortality is much higher in emergent repairs. And so you need to have an informed discussion with the patient that, hey, you may not be symptomatic now. Make sure you come back and see me if that changes. We don't want this to become an emergency. There is no evidence that says that watchful waiting is a good management option in symptomatic patients. So again, it comes back to the symptoms that patients have, and we'll talk more about symptoms here in a minute. Those who don't have symptoms will likely develop symptoms over time. So that's an important part of counseling and discussion with your patients. And we know that while most will develop symptoms, that buys you some time to plan around their life in terms of when to fix it. Lastly, and most importantly, the absolute most important part of this discussion is the one with the patient. Where do they live? What do they do? Do they have easy access to care? Do they have difficult access to care? Do they have people around to help them? Do they not? They live out in the sticks or they live in the city. And so you need to discuss these with the patient, and that ultimately dictates your treatment discussion. With those symptoms, I think that a lot of symptoms go unappreciated. The classic ones we worry about are groin pain and groin bulge, but other symptoms that are often maybe not appreciated will be urinary symptoms, hip pain, lower back pain. Those can oftentimes be the presenting symptoms. Have a relationship with a lot of the sports physicians in town, the medical sports doctors, and a lot of the referrals I get from them are actually patients who presented with low back pain and throughout their diagnosis ended up identify that a hernia. So need to consider those atypical symptoms as well. In terms of special considerations, especially when talking about when to fix or if to fix, femoral hernias, I think warrant special discussion. I think they're often underappreciated and overlooked. I think this is true in both men and women. We know that femoral hernias are more common in females. Traditional literature tells us that. However, anecdotally, and we're going to start looking at this, I think a lot of men have femoral hernias as well. And I think that we just get fixated on the indirect direct space. And doing I do a tap repair, so I go intraperitoneal and a preperitoneal approach, get well below the pubic bone. I'll show a picture of that later, but identified that men have femoral hernias too. And looking at that, we know that it's important to identify those because the risk of incarceration in femoral hernias is much higher. Direct or indirect, only 2 to 4% will incarcerate at 3 to 21 months. That's up to 40% in femoral hernias. So it's very important that we identify these, especially if we do decide to operate, we need to identify that space and reinforce it. Still with femoral hernias, it's very difficult to determine a femoral hernia on exam. Even with imaging, it can be difficult. CT is the best way, although we know ultrasound is the best imaging modality in general for inguinal hernias. CT is better to identify femoral hernias. Even if you don't suspect it, or even if it's not obvious on exam or history, you need to be thinking about it for each patient, men and women. What's interesting is that women who have had failed an anterior approach, 40% of the recurrences that women experience are femoral hernias. And for men who have missed hernias or untreated hernias, 10-fold risk that that's going to be a femoral hernia. So we need to identify those early and avoid recurrences. With that, identifying again with women with these hernias, similar to athletes with low back pain being identified with inguinal hernias, women, I think, go undiagnosed for years. On the very first slide for the epidemiology, it showed that women are typically diagnosed with inguinal hernias in their 70s, men closer to the 50s. And I wonder if that's true because of anatomy or if it's true because diagnoses get delayed because we think of gynecologic issues or pelvic floor dysfunction. And so I think it's important that we identify these in women and offer them repair. Other considerations to repair or not, pregnancy is a big one. Oftentimes women will get referred for groin bulge during pregnancy. It's oftentimes not a hernia. Get an ultrasound and show it's a varicosity of the round ligament. There is it's low incidence, also low incidence complication. Watchful waiting is the default right answer for those patients. Also, patients with ascites, you can offer them repair, but data suggests it needs to be an extraperitoneal or anterior approach. Current data does not support transabdominal preperitoneal repair, although I do think that we're going to see some studies that are going to suggest otherwise. So with these things that we know in terms of how to treat, so the hernia surge group put together this simple algorithm for uncomplicated hernias. Do you have a hernia? Yes or no? Are you a male or a female? If you're a female and you have a diagnosis of a hernia, even if it's asymptomatic, recommend repair. Of course, factoring in patient's overall surgical candidacy. But if a female has an identified hernia and they're not pregnant, you should offer a repair. For men, if they have a hernia and symptoms, again, considering all atypical symptoms, repair is generally recommended. And special considerations for that would be, have they had a previous lower abdominal surgery, prostatectomy, hysterectomy? Current literature or traditional literature says that we should not be offering transabdominal repairs on those patients. And there's a lot of data coming out. Very fortunate our group just had a paper accepted for publication on a similar topic that it is feasible with good outcomes doing surgery in the pelvis, even if the patient's had previous pelvic surgery. The other on this list is irreducible or inguinal-scrotal hernias that we shouldn't do minimally invasive repairs for those. And I think that similarly, there's going to be a trend showing that those are reasonable and in some situations favorable to approach those hernias from a minimally invasive approach. In terms of trends, we see that in terms of how to fix these once we get there, traditionally they've been open repairs. We see the best data I found is up until 2019, and we see an upward trend in minimally invasive repairs and downward trend in open. And we'll see next slide why that is. What's interesting in looking at those trends, however, over time, looking at men versus women in terms of repairs, the left side of the screen is a unilateral approach, and you see that up until 2017, 20% of men were fixed minimally invasive and only 16% with women. Interestingly, for bilateral repairs, which we know minimally invasive is favored for bilateral repairs, there's a 13% difference in men versus women in terms of who's offered minimally invasive or not. And honestly, I think it should be flipped. Again, making sure that we're identifying those femoral space, and it's easier to do that minimally invasive. Shorten myself on time, but in terms of minimally versus open, complication rates are now comparable. Lap cases do have a higher learning curve, 250 cases is what's quoted. With robotics, you'll see a little lower than that. Cost is now actually similar, open to laparoscopic. And you have to look at things like money saved rather than money spent. And so cost is an interesting discussion now as well. And outcomes overall, patients like it better. Very quickly, in terms of the importance of avoiding recurrences, initial repairs are typically easy. Recurrent ones can be more challenging. It's important that we identify all three spaces of the myopectomy orifice. So in this picture, screen left is medial, screen right is lateral. This patient has indirect defect. This is where the direct space would be. This is where the femoral space would be. And you can see that the dissection extends well below that, below the pubic bone. It extends in this line down. You drop the bladder down, and I have some residents here in the room that I always think I'm funnier than they think I am. They roll their eyes, but I've named this space. This is called the vas crack. And I call it that because you have to free up the vas deferens so it lays flat against the pelvic wall. Once you have that vas crack clean, then you know your dissection is done. So you can see this repair on the right side, that dissection is below the myopectomy orifice, mesh goes below that, and it's important that you get that. Whether you're doing it open, laparoscopic, or with the robot, you need to have this clear dissection each time, and that's going to significantly drop your recurrence rates. So symptoms, direct care, look for atypical symptoms. Femoral hernias require special consideration. They're often underdiagnosed, but ultimately repair type, duration, or timing depends on discussion with the patient and what the surgeon is comfortable with. I'm sorry for an overtime. I appreciate you guys.
Perfect.
These are my helpers for my talk, so thanks for that.
All right. All right, welcome. Any questions? What do a patient comes to you, has symptomatic right inguinal hernia, has mildly symptomatic left inguinal hernia. So when you go there to repair, you address both at the same time?
Same time. So typically, say a patient does not have symptoms on the left, only on the right. I don't suspect the left side. I consent for a bilateral every single time I take a patient in the operating room. And I talk with them, if you have an obvious defect, I'm going to fix them both. And the patients are usually good with that. The risk for chronic pain, which again, pain is always hard to exactly delineate, but I quote them about a 5% risk of chronic pain. I think that's kind of where the data is leveled out. And most patients are agreeable with that.
Hey, Alex, Chad Hall from Temple, Texas. Great talk. I was curious, going back to even the prehab talk before you, I see a lot of patients with inguinal hernias who are obese and smoking, if ventral hernias are different, but I wouldn't offer them a ventral hernia repair if they had one. What about for inguinals? Are you denying certain BMIs or smoking status?
Great question. In fact, Josh Gearman sitting right there, and about a year ago, we had an M&M where we were talking about this. But I do not have those restrictions for inguinals. And the reason why is that the anatomy is different. When you're in the pelvis, you have that bony bowl that acts as a reinforcement. And so you're not relying on the anterior abdominal wall and the laxity of that to aid in your repair. I do have those strict regimen or strict criteria for abdominal wall hernias: smoking, diabetes control, weight loss, BMI absolutely less than 40, ideally less than 35. But I don't have those for inguinals. I think risk of infection is much lower, especially the minimally invasive approach. And interestingly, the increased intra-abdominal pressure may actually help our repair in pushing our mesh into the pelvis and helping reinforce that. So maybe actually be beneficial.
So for hernia repairs, you want to say gain weight? Yeah. That's before surgery. That's what makes you understand.
The transcript is stopped right now.
Gain weight.
All right. Thanks, everybody.
Inviting our next speaker, the title of the talk is Managing the Surgical Patient on Anticoagulants. Dr. Justin Regner, he's the Trauma Medical Director and Division Chief of Trauma and Acute Care Surgery at Temple in Texas.
All right, thanks, everyone. There's gonna be a lot of information. I'll try to talk slow. Mainly I'm from Texas, so we do talk slow. I don't have any disclosures. I do have a personal disclosure. I ruptured my Achilles about 3 months ago. I was in a cast for 6 weeks. And while in a cast, I started having more leg pain. And one night I woke up in the middle of the night with severe chest pain. I did not put 2 and 2 together. Eventually I got back to work in a boot. And I came home from work one day. I was like, man, my leg is so swollen. I've got to get off it. My wife's like, are you sure something's not going on? And so I called my buddies up and I went to the ED. And sure enough, I had a DVT all the way up to the femoral canal. Anticoagulation is part of my life now. And so I think of it differently than I did 5 weeks ago. You know, I think we're going to talk about a lot of things. Some of it we'll go through really quick because y'all know it. It's just a refresher, you know, the clotting cascade and the types of anticoagulants. I think it's important to know the mechanism of action. Reversal agents, while few need to be discussed, we're really going to talk about why our patients are anticoagulated. And not just why they're anticoagulated, but what's the risk of them having a thromboembolic event and what's their surgical bleeding risk. And this will be how we determine our algorithm for management. I think before you get into it, if you're looking for this talk to tell you all the ways to emergently reverse patients and take this back to your hospital, that's not a great choice. Everyone should already have an reversal algorithm. So when that patient comes in hemorrhagic shock, no one's thinking, everyone's acting. And if you don't have one, please talk with your pharmacy, hematology, and cardiology so you can develop it for those patients that are actively dying. If you see a picture with the little camera on the bottom, there's only like 3. And you want to take a picture, I would take a picture of 3 slides only. Otherwise, you can, snooze, nap for the rest. No matter what happens, I think the most important thing we talk about this is what the patient wants. And that's to have the same life, same length of life, and the same quality of life as an age-matched cohort without the disease. So for me, my biggest fear is that next chest pain event going to be, the lethal blow? So my fear is different than the surgeon's fear was, I don't want the patient to bleed. So I think we have to change how we think about it some. Anticoagulants are part of a greater group called antithrombotics, which include antiplatelet medications and anticoagulants. And the whole goal is to reduce the risk of forming clot. We're not going to talk about antiplatelet medications a lot. There's a bunch of them, whether you test using a bleeding time or a PFA or, verify now or some TEG or viscoelastic property. Every institution does it different. There's no real way to reverse any of these medications. And most of them say give desmopressin, platelet transfusion. Not real complex. For the clotting cascade, and this is real small, the key is that the medications that we use to stop anticoagulation occur at the bottom, factors 10, 9, or 2, which is thrombin, which is those right there. That's where all our medications work. They work on the sequence right before the fibrin clot. The types, everyone knows these. We have heparin moieties, the vitamin K or Coumadin, we have direct thrombin inhibitors, and we have direct factor 10A inhibitors. Your heparin moieties include unfractionated heparin, low molecular weight heparin, fondaparinux. The goal of all these is to bind antithrombin and inhibit either factor 10 or factor 2. You can monitor their activity with an anti-factor 10A. For heparin, for the most part, it binds antithrombin and both inhibits factor 10A and thrombin. Low molecular weight heparins bind antithrombin and only inhibits factor 10A. Same with fondaparinux. So they bind the same molecule, but because of constellation changes, their actions change. Vitamin K, we know this decreases factors 2, 7, 9, and 10. It's a true decrease in the actual amounts of those factors. You can monitor it with an INR. Your direct thrombin inhibitors, the only ones that actually have a parenteral or IV form and an oral form. For the parenteral forms, you can usually monitor an activated clotting time or an INR. For the oral form, you can use a thrombin time, an APTT, or an activated clotting time. All of these are reversible direct inhibitors of thrombin or factor 2A. Your 10A inhibitors, there's only 3 that are approved in the US right now. One of them was taken off the market. We know these 3. I'm sure all of us have taken many patients to take care of many patients with these. They're all reversible inhibitors of factor 10A. You can use an anti-10A factor SA for that specific drug. When it comes to your reversal for anticoagulation, your heparin moieties, the 2 low molecular weight and unfractionated heparin, both can be reversed with protamine. Protamine works better for unfractionated heparin than low molecular weight heparin, but it still works. Fondaparinux does not have a reversal, and you can possibly give 4-factor PCC. Vitamin K, you're given FFP or 4-factor PCC. Your direct thrombin inhibitors, thankfully, bilirubin and argatroban, both have short half-lives because they do not have a reversal agent. So turn off the drip, maybe give them 4-factor PCC. Dabigatran, y'all can read that word. I have no idea how to say idaruzumab, or factor PCC. It does have a reversal agent. And then, your direct 10A inhibitors, everyone knows Adnexa. No one knows which ones to choose. Everything's about cost. The talk is not about looking at this. There's lots of small retrospective studies. In the last year, these are the two largest retrospective studies. One's pro-Adnexa. It was sponsored by AstraZeneca. It used the Adnexa 4 clinical trial patients and compared to a retrospective cohort using 4-factor PCC, using reverse propensity matching. It basically said Adnexa was better at hemostasis and survival. Surprise. The retrospective study that was not sponsored basically said there was no difference. And the real issue gets into no one really knows how much 4-factor PCC to give. It was designed to reverse your warfarin basically, and it used basically INR to determine how many units per kilogram you gave. So we don't really know how much to give. Do you give 25? Do you give 35? Do you give 50? My institution says if it's a day out and they're still oozing, maybe you give 12.5. So no one really knows how much to give. Because no one knows how much to give, it really changes the validity of the studies. Thankfully, Adnexa 1I is currently active. It's a phase 4 trial currently comparing Adnexa to 4-factor PCC. The downside is it's going to be usual care with 4-factor PCC. In other words, we don't know whether they're going to use 25, 12.5, 35, or 50. So the validity of this study may be compromised by not knowing the comparative study. When it comes to anticoagulation indications, there's lots of indications from VTE treatment, prophylaxis, AFib, prosthetic heart valves, heparin-induced anathrobes. The risk, when we think of thromboembolic events, you got to categorize into low risk and high risk. So low risk is, aortic valves, low CHADS or CHAD-VASc AFib scores, or VT has been treated at least 3 months. High risk or newly diagnosed VTE, i.e. me, or patient with high AFib scores or mitral valves. Bleeding risk, low risk or minor procedure. What's a minor procedure? To that patient, it's always a major procedure, but maybe lap choles, maybe the inguinal hernia repairs, maybe some small soft tissue stuff, or bleeding that's not going to cause major loss of function, specifically like intracranial bleeding or spinal bleeding in joints. They may not hemorrhage to death, but it only takes a small amount of blood to cause a major loss of function. So we consider those high risk procedures. This gets to the goal of talking, what do we do? Our goal is to minimize bleeding and minimize thrombotic risk. It's going to include when to reverse, when to bridge, and when to resume anticoagulation. So you can basically put these people in 4 buckets: the low risk bucket, low risk, low risk, and high risk, high risk. So if you're low risk, you stop your DOACs 40 hours before, resume in 24 hours after surgery. Coumadin, you hold 5 days before, you can resume at the date of surgery. Low risk thrombosis, high risk bleeding. Now it's 48 hours and 48 hours for your DOAC. And for Coumadin, you still hold 5 days before, but you resume 1 day after surgery. Now, if they're high risk of thrombosis, this is where, it changes a little bit. For DOAC, it's 24 and 24, but for Coumadin, this is where I think we really need to consider using a heparin bridge up until the day before surgery. You don't want a major thrombotic event. Your high risk, there's your DOACs 24 and 48. Your Coumadin, I would, for this patient, choose a low molecular weight bridge both before and after surgery so you can reverse it if they do have a major bleeding event. You want a nice graft. This is for DOACs. High risk bleeding is 48 hours before, wait a day. Low risk 24 before, start the next day. This is, I'll get to it. I almost got excited. As surgeons, there's no published results about how to operate on somebody on this stuff and prevent bleeding. Like, we haven't published that yet. I've unfortunately or fortunately had to operate on people on heparin drips numerous times because of other events that have going on that the consulting team said we just can't stop it. And I've taken to the OR. I choose minimally invasive techniques when able. I think less tissue damage decreases bleeding. I do not do blunt dissection if someone's on any anticoagulant or if I can't hold it. Everything I do is sharp dissection with a bipolar device. If I have to make an anastomosis, it's always with 3 rows of stapler, where it's an endo-GIA or a GIA. And if there's any raw surfaces, I always leave a hemostatic agent. It's been fairly safe. This is the most important thing to take a picture of right here. You can put it on your phone or you can go to the website. This will tell you how to reverse your patient and how to do it. So if you go to this website, you go to the next page, they list all the anticoagulants on there. You can choose it. I chose Xarelto. You can choose your bleeding risk. You can then choose your thrombosis risk, and then it'll tell you exactly when you should stop. They say 3 days before and resume 2 to 3 days after for a high risk patient. So once again, that is the most important slide. You're not going to remember anything I said, but if you can remember this, maybe your patients will benefit.
All right, thank you. Invite any questions. You mentioned some of the things you may do differently during an operating on someone with high risk. Taking big vessel, would you change, you know, if you're using an energy device, would you now use a stapler or just, you know, tie them? Does that make any difference?
I think if it's above 5 millimeters, I'll use a stapler for microscopic. Actually,
In general?
in general.
So you don't-
not in general. I mean, I think if they're on anticoagulation,
Got it.
otherwise I'll take it with energy device.
Got it.
I'm not worried about it.
Office-based procedures.
They recommend for office-based procedures, you do not stop anticoagulation under any circumstance. You use a little extra epi or a heat source if you need to, but don't, for an office-based procedure, don't stop your anticoagulation. Now, if they're a low thrombotic risk, maybe they're on VTE, maybe they're lifelong, maybe they have recurrent VTEs, maybe you can stop it for that. But for anyone else, a little local bleeding at the skin is not worth a major thrombotic event.
For us, the colorectal surgeons, when it comes with treating hemorrhoids,
Oh,
we
well,
do differentiate.
that's fair.
We do differentiate. You know, are we being aggressive and rubber banding the hemorrhoid versus injecting him? We probably take the path of least resistance. if
Well, I would
that's-
have, with that office-based procedure, I would say is a high bleeding risk.
Right,
So it changes your algorithm.
correct. Okay,
All right, thank you.
thank you, guys. Thank you. All right, more down my alley. Updates in inflammatory bowel disease. Dr. Cynthia Tom, the assistant clinical professor in Department of Surgery, UCSF.
President, yeah,
Oh, UCSF Fresno.
yes,
All right, welcome.
okay. Yes.
Okay, okay. So I'm gonna be talking about updates in inflammatory bowel disease. I have no disclosures. So very broad topic. So I just kind of distilled it down to something. So I'm gonna just talk about the evolving treatment paradigm in IBD briefly. Some of the newer biologic medications in Crohn's disease, and something of more interest, a hot topic recently in kind of the colorectal literature, the conal S anastomosis. So in terms of the treatment paradigm for IBD, it's been evolving in recent years as we learn more about the pathophysiology of IBD. So pretty much traditionally, the treatment for IBD has been a step-up approach, or some people do like a top-down approach. But pretty much, you know, you start with 5-ASA medications, sulfalazine, mesalamine. And if, you know, the patient doesn't respond, still has symptoms, go to steroids. And then immunomodulators, like 6-MP agents, and then biologics, which we know as infliximab or Remicade, adalimumab, Humira. And then when patient is refractory to medical management or has a complication, surgery. However, you know, with IBD, there's so many different phenotypes. There's fistulizing phenotypes, stricturing phenotypes, penetrating phenotypes, and each patient has such a differing severity of their disease. So kind of a blanket approach is really not, you know, it's probably not going to be beneficial for all patients. So usually, you know, you want to do a personalized approach. And so pretty much there's now kind of different, or some organizations like the International Organization for the Study of Inflammatory Bowel Disease, they kind of have some expert consensus guidelines, kind of looking at more target to treat strategies, so that, you know, looking at each patient's prognostication, looking at early intervention, treating to targets, tight monitoring of drug levels and adopting of a more like, individualized approach. So kind of some of the new things is like, whenever I think of CRP or fecal calprotectin, the CRP levels, I only see it when we track it in-house, like a patient that's acutely hospitalized for IBD, like a acute ulcerative colitis flare or Crohn's flare, and they're trying to see like, okay, they start some steroids in-house, want to see that CRP trend down. But in the outpatient setting, I don't usually see CRPs trended. Fecal calprotectin, I'll see it for the initial diagnosis of IBD, but I don't know if that's something that we really like trend. So they're just kind of looking at, not using it as a defined endpoint to define disease, but kind of looking at it so that, maybe that's something we can monitor. Because usually when they go to the GI docs, they'll start the medications. It's kind of, they go by symptoms. And then maybe sometimes they'll do an repeat endoscopy to kind of look at mucosal healing and stuff. But really kind of defining targeted treatment for IBD is kind of something that is kind of being worked on. So then we'll go over some of the newer biologic medications for Crohn's disease, nothing crazy. So all of the FDA approved biologics for Crohn's disease, the ones that we see the most is going to be Remicade and Humira. Remicade initially approved in 1998. It's first line recommendation for like severe Crohn's disease. Humira is also common. I've seen Cimzia occasionally, but not too much. It is around though. You'll see some people on it. Tysabri though, you'll see it's FDA approved. It's initially for people with multiple sclerosis, but if you do see someone on it, just know that they have a risk of developing progressive multifocal leukoencephalopathy, which is not good. So if you see, it's going to be rare that you'll see a patient on that. The more newer ones that you will see will be vedolizumab, Entyvio, ustekinumab, Stelara, which came out within the past 10 years. And actually just last year, they came out with Skyrizi, which I've only seen one patient on. Skyrizi, there's been a couple of randomized trials on that. And actually it's pretty promising for patients who have failed other biologics. About 40 to 50% of them when put on Skyrizi after about 3 months showed clinical remission. So kind of promising. So excited to see if that, evolves IBD care further. And this is just from one of the gastro and GI societies, just kind of your first line treatment for severe Crohn's disease is still going to, with all those, medications and stuff, is still going to be infliximab or adalimumab, so Humira or Remicade. Your second line is going to be like, if they fail Remicade or Humira, is going to be Stelara and Entyvio. And I think a lot of it is, that is probably based on cost and stuff. So still your first line is going to be Remicade and Humira, but just know there are other options. So take home point for this slide is kind of like when you're in the office or if you're in the hospital, usually when in the hospital, the patient's pretty severe, but you'll get the consult like, the patient's refractory to medications. Do you want to, do an ileocolectomy, or if they have Crohn's colitis or ulcerative colitis, do you want to do a total abdominal colectomy? This is, this is Crohn's. So for Crohn's colitis, do you want to do a, colectomy for the patient? And it's just kind of to know that the broader kind of medical treatment out there. And a lot of times it's going to be a multidisciplinary discussion with the GI doctor. Like, you've maxed out all these things. This is the patient's symptoms, and kind of, working with them together to discuss surgical options. Okay, so this one's more interesting. So the conal S anastomosis. So this is kind of a hot topic in the colorectal literature in the recent years. So this is a technique created by Dr. Toru Kono in Japan in 2003. It's essentially a hand-sewn anti-mesenteric functional end-to-end anastomosis. And so the reason why this is kind of a hot topic, because a surgical procedure that can reduce the recurrence rate of Crohn's disease. And so that's what it's proposed to do. Now, there's been one randomized control trial, I think out of Italy, but I think it had pretty low study numbers, but pretty much, there's two other randomized controlled trials kind of pending on this, one in the US and one in the UK, kind of comparing the conal S anastomosis versus the formal side-to-side anastomosis, stapled anastomosis that we do. And I think the one in the UK is also comparing extended mesenteric resection. But yeah, so I'm just going to really quickly go over the conal S technique. So the main kind of principles of this Kono S anastomosis is one, it has a supporting column, which I'll talk about a little bit more. It has a wide anastomosis. The enterotomies used to make the anastomosis is 7 to 8 centimeters in length, and preserving the mesentery under the resected bowel. So first portion, of this technique. So one, you resect the diseased portion of the intestine, the strictured portion, the inflamed portion. And the goal in that area is to preserve the mesentery. So you hug the bowel wall, take the mesentery just right under the bowel wall. And this is proposed because to avoid devascularization and denervation of the actual residual bowel in the anastomotic site. Then when you resect the affected portion of the intestine, I think they do it, the orientation is like 90 degrees to the way we do it. So you want to transect with a stapler, and then kind of in that diagram, normally when we transect the bowel, your anti-mesenteric side is in the crotch of the stapler when we do our side-to-side anastomosis, or at least that's how I do it. And then, but this one, you want the anti-mesenteric aspect not to be in the crotch, kind of in that picture where that blue line is. You want it to be in the center of the stapler. And that's to set up your anastomosis. Then you create this, what he calls a supporting column, or the backbone of the anastomosis to kind of support it. So those two stapled ends of the bowel, you're just going to suture them together. You're not creating anastomosis, you're just suturing it together. And that's to maintain orientation and prevent distortion. Then you create longitudinal enterotomies, 7 to 8 centimeter in length along the anti-mesenteric lumen. Or along the anti-mesenteric aspect of the bowel. And it's supposed to be like in his paper, there's a lot of papers talking about this technique. You can look it up, really good diagrams, about 0.5 to 1 centimeter from the supporting column so that you can create the anastomosis. And then it's a hand-sewn anastomosis. And it's anti-mesenteric, completely anti-mesenteric. So, the reason why he proposed that, this is beneficial and it remains to be seen based on those randomized controlled trials is there really less recurrence of Crohn's disease, but is because one, the supporting column prevents distortion. Two, it's a functional end-to-end. So when you endoscopically survey these anastomoses afterwards, it's pretty much like an end-to-end. When you have your side to side, it's, when you scope, it's really hard to get that turn to see. And so sometimes maybe you don't see it well. So this is easier to survey, and then less fecal stasis. And because it's completely anti-mesenteric, usually the recurrence occurs on the mesenteric side of the bowel. And there's a whole bunch of literature talking about the pathophysiology or the creeping fat and how that plays a role in the development of Crohn's disease. But that's a bigger topic. But that's all I got.
All right, thank you. Any question?
Yeah, I've got one. Dr. Tom, that example you showed was ilium to ilium, it looked like.
Yeah.
Can you do that same anastomosis, ilium
It's
to
been-
colon?
Yeah, it's been described for ilium to colon. And then I guess technically you could do it for colon to colon, but you would really have to mobilize the colon. But yeah, and then there's if you look in the literature, I think people talk about doing it. I didn't click on the paper, but you can do it stapled, robotic, but the classic technique is described as a hand sewn.
Hi, Rishi Batra, great talk, UNMC colorectal as well. Are you doing this in your practice? I saw this once as a fellow, and did you do this as a fellow, or where do you think we go from this?
I saw it once. I'm 2 years in the practice, so I saw it, and I haven't done it. I'm excited, but the thing with this though is that the techniques, it's not TANIS or something like that. People can't do, anyone can do that. It's you staple and it's a hand-sewn anastomosis. So I think I personally haven't done it. I'm curious to see, what those other studies are going to show. Does it truly decrease, risk of recurrence and stuff? And so if it does, then I probably would start doing it.
And have you seen patients asking about this? I mean, I'm only 6 months into practice. Okay.
No, I haven't seen any patients asking about it. There's actually a really good on a DCR, the diseases of colon and rectum. They had a recent debate on this, and one surgeon was saying she does this routinely for all her anastomosis. Some people say they do it only for high risk of recurrence. But yeah.
Okay, thank you.
Dr. Langenfeld, will you put down Twitter, please, and comment on this ConoS anastomosis? Are you doing it?
The data for lower endoscopic recurrence rates is really good for this anastomosis. There's two camps in Crohn's disease, the anti-mesentery and pro-mesentery camp, because we know that the mesentery mediates some of the inflammation. This anastomosis, it basically excludes the mesentery from your anastomosis, which is probably why our recurrence rate is low. It's technically an external thing. A lot of us are doing intercorporeal anastomoses now. So in the community, the utilization is under 5% based on some Facebook polls I did in our close Facebook group. But the reality is, as people get more savvy with it, it's going to be more common robotically. I have done them. They seem to do just fine, if that makes sense. But the thought leader is Alessio Ficara, who's if you guys ever want to find out like how to do it, a lot of videos online. So
Yeah, there's a lot of videos, a lot of diagrams online. Yeah. So do you commonly do it routinely, or do you kind of select patients that are high risk?
selective,
Okay.
just to try it out. I would like my old fashioned stapled anastomosis too. But this is a brand new thing, but the data is really getting harder to ignore because there's randomized controlled trials showing benefit.
I gotta tell you, this is my the fourth talk I've heard on ConoS, and every single time the actual speaker says, I don't do it. And you know, and the top before this, what people were talking about is removing as much of the mesentery as possible, right? Staying farther away from the bowel and taking the mesentery. And when you talk to people who've done both, or have actually started doing both, I think they still resort to removal of the mesentery, you know, if possible, not always possible, because sometimes it's thick, edematous, etc.
Right.
Because this is a whole learning curve to get to this point.
Alvin Coffey is like the thought leader on the wide mesenteric resection. And so he's the contra, you know, to what you're talking about. But this is important stuff. And Dr. Kono recently died, rest in peace. But this is probably 10 years from now, it's going to be a different makeup of how many people are doing it. So
watch this space.
But yeah, there's a randomized control trial, I think, coming out from the UK. I don't know when it's going to end, but it's called the Meerkat, but it's like extended mesenteric excision versus ConoS.
Oh, that's right.
So they're actually comparing those two. But yeah.
Right. Perfect. Thank you. Okay, last but not least, to give or not to give antibiotics and when to stop. Natasha Carrick, she's the Associate Professor of Surgery and Surgery Clerkship Director at the University of Arizona. Welcome.
Thank you. Just to know, green is go. Okay. All right. Good morning. I know it's been a long session, so I appreciate the engagement and good questions. This topic, I think, is a great topic. In fact, I think all these talks have been really, really good. But today we're going to talk a little bit about when to give antibiotics, when to stop, and really when to de-escalate. And you would think that this would be very well delineated out in the literature, but very similar to the first talk, there's still a lot of controversy around it. I have no disclosures. The objectives of this talk are to define the scope of the problem, talk a little bit about current recommendations, summarize best practice, and then just give a little overview on some future studies. So why are we talking about this and why is it even important? Well, the CDC actually put out that antimicrobial resistance is a global threat, is what they call it, global threat. 5 million deaths, and they talk about 2.8 million related infections, with a greater than $4.6 billion annual cost in the United States. And this was also mentioned in the Lancet article here, and I have these QR codes if you guys want to pull up the articles, if any of them are interesting to you. So antibiotic stewardship is a big deal. And the Society of Critical Care Medicine issued out this edict through the Choose Wisely campaign to don't continue antibiotic therapy without evidence of need. And they talk about employing microbe-directed therapy and limiting to the shortest effective duration and discontinuing once adequately treated. But as we know, that's not so easy for our patients, and especially ones that we've operated on, that we've been in the abdomen and they have had gross contamination. It's not so well defined. But the surgical infections put out a call to action for surgeons and basically said there's a global battle against antibiotic resistance. Surgeons can be and are pivotal leaders. And if you fail to engage, this will lead to loss of autonomy to treat. So we have to be at the table. We have to have a seat at the table. So what are the current recommendations? Well, if you go through most algorithms, you'll see that if there's an infection, you get source control, you'll start antibiotics, you'll get back your cultures, you can sort of tailor the antibiotics based on the cultures, and then you'll eventually stop the antibiotic therapy. But when do we start? How do we de-escalate? And how long is the treatment is really where we sort of battle it out. So when do we give antibiotics? The surviving sepsis guidelines have a really great, obviously, algorithm and all of the effort that they put in to give us that evidence-based practice. And even without the sepsis guidelines, we know that early treatment is really key. And dating back to in the 90s, even they showed that if you start your antibiotics early, it improves mortality. And in fact, every hour delay increases the mortality by 10%. And that really hasn't changed much. The black bars will show the mortality rate if you don't start antibiotics, and the white bars show that the mortality is improved with antibiotic treatment starting earlier. And then start empirically. But what does that mean? And they talk a lot about making sure that you pay attention to multi-drug resistant bacteria and fungal infections, because perhaps starting very empiric broad therapy is not always the right answer for all your patients. And in fact, they can actually not improve outcomes and make them worse. So when do we de-escalate? And that's the big question. So we know that you have to start the antibiotics early in order to minimize that risk of mortality. But then the longer that you have them on antibiotics, there's a higher chance that you have microbiome resistance. And then we get into this whole de-escalation. So I'm going to talk about three things in particular. I want to talk about the Stop It trial, which I thought was a really bold trial and a good trial written by many of our surgeons that attend this meeting here, well respected in our community, and procalcitonin, and then talk a little bit about artificial intelligence and where that is heading, especially for surgical infections. So let's start with the Stop It trial. This was a trial that was in 2015, and there was a randomized controlled trial. There were 513 patients. There was a control group, and the control group was basically that they would give antibiotics with a maximum duration of 10 days, or the experimental group, where it was a fixed dose of antibiotics that they would give for 4 days, plus or minus 1 day, if they showed improvement clinically. So the primary outcomes that they looked at was surgical site infections, recurrent intra-abdominal infections. This was a study just looking at intra-abdominal infections, and then death within 30 days after index procedure. And then secondary outcomes looked at duration of therapy and then rates of subsequent infections. And what did they find? They found that in terms of the primary outcomes that they were looking at, there was really no difference between the experimental group, that fixed day group of 4 days, versus the control group. And this is their Kaplan-Meier curve here. It was not statistically significant, but again, I think very bold and brave, especially I know that many of us want to keep those antibiotics going for a long time. And then medium duration of antibiotic therapy, as they sort of proposed, 4 days in the experimental group, and then 8 days actually in the control group, which was statistically significant. So what about procalcitonin? And I always laugh when I talk about it on rounds. It's almost like the platform heel that's coming back. It's not new. It's been around for some time. It's a precursor of calcitonin, and what it does, it really produces an exposure to bacterial toxin. And it will increase 6 to 12 hours after stimulation. It's got a half-life of 24 hours. So technically, it should decrease by half if the infection is controlled or if it's responding to your treatment. Turnaround time is about 20 to 60 minutes. And several meta-analyses are looking at its utility again. And again, this is not new, but one of the trials is the ProRata trial. And the reason I like this trial is that it's just not really focusing on sort of respiratory infections, which procalcitonin, they look a lot into those respiratory infections. And what this was a prospective randomized controlled trial, 621 patients who had suspected bacterial infections. And they looked to see if procalcitonin guided therapy versus just the current guideline therapy without procalcitonin, did it make a difference? And they use these concentration cutoffs less than 0.5. Basically, they recommend stopping antibiotics. Greater than 0.5, they say start or escalate. And their primary outcome is mortality at 28 days, 60 days, and then number of days without antibiotics. And so what did they find? Well, the outcomes and the survival were the same between the two groups, which was interesting. And also, I would say not unexpected, but the procalcitonin group had less days of antibiotics. So it was about 10 days versus 13 days in the current guideline group. The SAPS trial, very similar. I'm not going to go too much into it, but just again, another design very similar to the ProRata, a little bit more patients. And they looked to see that with procalcitonin guidance, was there a difference? And they noticed that there was less antibiotic use, and the 28-day mortality was lower. So in terms of AI, because a lot of this is, well, how do we detect infection earlier? And can we? And are there certain things that we can look at, not just the laboratory data, to help us discover the infections earlier and treat it earlier? So there's a lot of talk on this. This was actually a great article that talked about an AI program that they wrote in the Netherlands that had some good data, but it was just really hard to extract to other places, which I think somebody had brought up. It needs to be something that's mobile, something that's on your app, and something that is easy to use. Otherwise, it won't work. And then for best practice, folks got together and saw if they could create some guidelines, but very low quality of evidence on anything. So timing is everything. Start early and try to end early. Procalcitonin is a guide. It's not the end all be all. De-escalation is not unsafe. And exercise clinical judgment. You are the steward. Future studies on the horizon. This is just out of surgical infections. They're doing a study on minimizing VAP therapy to 4 days versus 7. So something to pay attention to that's going to be coming up. And with that, thank you. This is my contact information if you have any questions. Thank you.
Thank you so much. It almost sounds like, or looks like nowadays we're in the era with antibiotics where we were with blood transfusions a decade and a half ago, where people liberally used to transfuse 2 units of blood. Now we understand that that's not the way to go. And now with antibiotics, there's definitely a push away. We know in our world, diverticulitis, we're treating without antibiotics. Now, at least there's a big push. There's data recently saying that intra-abdominal abscess being drained, you only need 4 days of antibiotics, etc. So I think, you know, all of us always have the regimens of 7 to 10 days of antibiotics, even in the office. But it sounds like we need, I think, maybe half of that. You know, we're in that era now.
Absolutely. And in fact, in that Stop It trial, they did look specifically at the colon and rectal infections. I think we always are, that's kind of always at the forefront. And definitely drainage and shorter duration showed sort of the same effect. So yes.
Yeah. All right.
Okay.
Thank you, guys. Thank you so much. Enjoy the rest of the day. Thank you.
And I love my app though. I'm going to use it.